We're broadcasting.
Great, thank you. So for those of you who are just joining us now, excuse me, just hang tight. We're going to give it a few minutes for people to get logged on. Alrighty, for those of you who are just logging on, just hang tight for another minute or so. We'll give people a chance to get logged on, and then we'll go ahead and get started. All right, I think we will go ahead and get started at this point. Welcome, everybody. For those of you who haven't joined us previously, hi, my name is Hilary Godwin, and I'm the Dean of the UW School of Public Health. And in general, this is a webinar that's for the UW School of Public Health community broadly defined. So we welcome alumni or members of the UW community who want to just jump in today. You'll hear us talk a little bit in the updates about stuff that's School of Public Health specific. So if there's something there that you're like, I wonder if that applies to me. If you're not primary in the School of Public Health or you work at some other organization full-time, then I would suggest that you contact your supervisor there and check out with them what the policy is. So in terms of how things work with the webinars, so this is, we've been running these webinars. We were doing them every week. We're on our summer schedule now, which is every other week from 3 to 4 p.m. on Wednesdays. And we start by providing COVID-19 updates and other important news for the School of Public Health and the UW related to COVID-19, followed by a special topic. For this, we do not typically use the raise hand function. So we welcome questions. We usually have a good set of questions and responses. So we'll have our panelists each speak for a little bit, and then we'll open it up to questions from the floor. Please use the Q&A function if you want to ask a question, and you can either leave it open-ended, in which case I'll try and direct it to the most appropriate person, or if there's a specific panelist that you would like to respond, just indicate their name. So this week's topic is the search for a vaccine for COVID-19. We have 4 outstanding and very well-known scientists with us today who are working on this critical effort and hopefully can shed some light for us onto this process. They are Larry Corey, Jim Kublin, Deb Fuller, and Will Hahn. And I'll give you more detailed introductions on each of them in a few minutes after we do our brief updates. So also joining us today from the School of Public Health, we have Carrie Farquhar, our Vice Dean for Education and a Professor of Global Health, Medicine, and Epidemiology. She'll provide some updates on what's going on in terms of education and student stuff for the fall and teaching. And we also have Janet Baseman, our Associate Dean for Public Health Practice, who's also, excuse me, a Professor of Epidemiology. And we have other folks from the leadership team here on hand and available to answer questions if we get some general questions from you, which we welcome you to ask. So first, just sort of launching into COVID-19 updates and trends. You know, I think you probably are all aware that, that we've had a rough month. Today we passed the 18.6 million mark for total confirmed cases worldwide, with global deaths totaling more than 700,000. And as always, our hearts go out to all of you who have lost loved ones or who have loved ones who are struggling with COVID right now. Nationally in the United States, we're approaching 5 million cases with over 157,000 fatalities. We've been averaging, excuse me, more than 1,000 deaths per day recently across the United States. I think probably everyone here shares the frustration of we're doing better here in Washington State and the Puget Sound region than some other parts of the country. But despite really having great coordination between elected officials and public health in our state and our county, we're still having challenges in terms of resurgence. So Washington State Department of Health is currently reporting that we have over 1,600 total deaths, over 5,700 hospitalizations, and nearly 60,000 confirmed cases. Across our state since the pandemic began, we've had more than 1 million tests performed. Our overall percent positive rate for the state of Washington is 5.9%. As you know, in response to the resurgence in cases, Governor Inslee has paused Washington's phased reopening plan indefinitely. And so the 17 counties, including ours, that are in phase 2, and the 5 that are in modified phase 1 are stuck here for a bit until we get things under control. The state also recently revised some of its guidelines for gyms, summer camps, bars, and taverns. Beginning August 10th, people working out in gyms will have to stay 17 feet apart, as opposed to the previous guidance of 6 feet apart. Summer camps, we've seen nationally some bad situations in summer camps that are sleepaway camps. So now in the state of Washington, we are not allowing members of different families to sleep in the same dorm rooms. In addition, in an attempt to tamp down on some of the recent surge of cases in Washington in individuals under the age of 40, the governor has pulled back on, so no indoor seating at bars or taverns, and that alcohol service has to end by 10 p.m. For those of you who haven't been following it, I definitely recommend, as always, checking out the DOH dashboard and our Public Health Seattle and King County dashboard, both of which are fantastic. A little glimmer of good news on the Public Health Seattle and King County dashboard and total number of cases per day is we're starting to see what looks like a leveling off on this most recent surge. Hopefully that's in response to the great response of the people of the state of Washington in terms of wearing masks and trying to bring the pandemic that's under control, and also the great work of our public health leaders and contact tracers in terms of, and testing folks in terms of getting things back under control. So thanks to all of you guys out there who are from those communities who are doing that hard work. Here at the University of Washington this week, actually just today, the UW finalized the autumn quarter schedule. And so you should have all received an email about that. Or if you haven't received it, actually now I'm thinking it may be going out tomorrow to the general community. So because of the resurgence in the virus, at this point we are anticipating that more than 90% of all of our class sections in the Seattle campus will be held online, and that only those classes that cannot be taught remotely will be held in person. And of course, in order to do that, those courses will have appropriate safety measures and physical distancing measures in place. So keep your eyes peeled for measure going out to students tomorrow, and similar updates to staff and faculty from President Kelsey and Provost Richards. So with that, I'm going to turn it over to Carrie to give a little bit more details in terms of back to school. Carrie.
Great, thank you, Hilary, and welcome to all the guests for today. I'm very excited to hear this presentation. So good afternoon. I would just like to add to what Hilary was saying about the courses. All of the school public health courses will be online, so any of you listening who are thinking about coming to Seattle, no need to come to Seattle per se. You can take all your courses remotely. They will be synchronous though. In some instances, there may be an asynchronous option. However, the plan right now is to have all courses synchronously in Pacific time. To help the faculty and also students manage this new remote learning system, we are advertising for a teaching assistant. So if any of you as a graduate student who's taken University of Washington courses before, or faculty or staff know of a graduate student who might be able to serve as a teaching assistant to support faculty in instructional design as they transfer courses to be online learning, or with the technical needs of Zoom and other technologies, please do apply. You should have gotten a notice either from your department or program, and it's also being advertised. So last update is that we are planning a webinar in the next few weeks that will focus on how to incorporate equity, diversity, inclusion, anti-racism principles into teaching. And these are for SPH courses. We want to ensure that faculty are able to modify their syllabi and use appropriate teaching techniques and approaches. And we have some really innovative ideas coming out of the Department of Epidemiology, Global Health. So keep your eyes peeled for that. Thank you very much.
Great, thanks, Carrie. And Carrie, are we still thinking that that's going to be the bi-weekly webinar 2 weeks from now?
The 19th
so
of
August 19th?
Yes, yes.
Okay, August 19th at 3 p.m. Okay, great, thanks. Janet, did you want to share some practice updates?
Sure, I'd be happy to. Hi, everybody. I guess I'll just start by saying that there's been a big organizational change at the Washington State Department of Health. They have reorganized to include a new outbreak division in order to continue their response to COVID. They're in the process of onboarding hundreds of new employees, including many of our recent grads. And I know I've mentioned this on prior webinars, but if you are a graduate student who has recently graduated and you do not have a job and are looking for one, email me because I may be able to help you get some employment. The other just quick update is around some new projects that the SEALs have been invited to help out with. We continue our work assisting our campus environmental health and safety office with contact tracing. King County is launching a new antibody surveillance project this week, and we're going to be helping support their ability to stand that up. We've been asked to help out the healthcare acquired infections team at the state health department, analyzing a ton of data they have on infection preventionists, infection prevention nurses and other staff at long-term care facilities across Washington. So we're in the process of helping them analyze those data. The final update is that I've been chairing the Washington State Bluetooth Exposure Notification Advisory Committee, which is informing making recommendations to the Secretary of Health and the Governor regarding new mobile technologies for exposure notification. We've met twice and have representation from the ACLU and the Attorney General's office and Yakima Valley farm workers and other community-based organizations looking at the public health value and equity and privacy and security of these new burgeoning areas of exploration with mobile technology to support our outbreak response. So a lot of exciting stuff. Email me if you want any more information.
Great, thanks, Janet. Okay, so awesome. We've wrapped up our to-do items, and now we get to turn to the topic of the day, which is the search for a vaccine for COVID-19. The question that I'm hearing most frequently from people this week, probably because they just want to know when is this going to end, is when might we have a vaccine? And so I frequently answer, well, it's a little bit more complicated that because we need to know when we'll have an effective vaccine that's widely available. And there are all sorts of other challenges like how long the vaccine is going to last and how we're going to distribute it. And I'm sure all of you guys have a lot more questions. So we decided that we would invite our local experts here in the Seattle area who are working on this problem to come and give us the inside scoop. So I've asked each of them to give a brief, like 5-minute overview of what they're doing, what they're involved in, and then we'll open it up to questions from all of you guys, which you can ask using the Q&A function. So let me introduce our 4 panelists, and then I'm going to have them each speak briefly. So first up, we have Deb Fuller, who's a professor of microbiology at the UW School of Medicine, and whose lab has been the site of development for a vaccine candidate. And for those of you who attended the February 19th COVID panelist discussion that was run by the Department of Global Health, Deb was one of the panelists from there and was fantastic, so we asked her back. We also have Will Hahn, who's an infectious disease specialist and clinical instructor in Allergy and Infectious Diseases Division at the UW School of Medicine. We have James Kublin, who's Executive Director of the Hutch-based COVID-19 Operations Program, who's also a clinical professor in the UW Department of Global Health. He's a principal staff scientist in the Vaccine and Infectious Disease Division, or VID, at Fred Hutch, and Executive Director of the HIV Vaccine Trials Network. And last but not least, we have Larry Corey, who's the former Fred Hutch president and director, who heads the Operations Center for the COVID-19 Prevention Network, which is a collaboration that was formed by Tony Fauci to manage multiple large-scale clinical trials of coronavirus vaccines. He's also a professor in the UW Departments of Medicine and Laboratory Medicine, and is known, among other things, for pioneering the development of antiviral therapy for human chronic viral infections. So super excited to have all 4 of you guys here. I'm going to hand it over to Deb. Deb, if you want to share your screen so that you can show slides, you're totally welcome to do that. And looking forward to hear what you guys have to share.
Do you guys see my screen okay? I just need to probably put it in presentation mode. Hang on a sec. There we go. Okay, so what I'm just going to tell you about is basically our short story on how we've actually been working towards developing one particular candidate vaccine. And when we got started really thinking about what would be needed for an effective pandemic vaccine, we thought about really features that was really going to be important. And one I think is really important is that it should induce immunity quickly. If you think about how most of our vaccines work, we started as children getting our vaccination over a course of years. Well, that's really not going to be a viable approach for a pandemic vaccine. We're going to need to have an immunity, ideally in a dose, maybe in 2 doses. The other thing that I think is going to be important is what types of immune responses that vaccine is going to have to induce. That was something we thought a lot about. Obviously, antibody is going to be very important, but we also think that T-cell responses are also going to be important for this particular vaccine. An important consideration is that it really needs to be effective across different demographics. Of course, we all know that the elderly are the most vulnerable to SARS-CoV-2, or among the most vulnerable. And so we're going to need a vaccine that doesn't just work only in the young and healthy, but it also has to work in the elderly and the immune compromised and people with comorbidities. So, and finally, what's really important too is that it needs to be really fast and cost-effective scale. And that's not always the case with all vaccines. Ideally, it'd be stable at room temperature so you can distribute it worldwide. So when we kind of looked at this sort of toolbox of things that we really wanted to accomplish, we looked at our own toolbox of different sorts of vaccines to see what kinds of vaccines would be able to accomplish that. Now, my lab has been working for a number of years on nucleic acid vaccine platforms. This is vaccines that you're all become familiar with now, RNA vaccines as well as DNA vaccines. They all seem new to you. They're not very new to me. They've been around for about 30 years. They just had a sort of a slow start because the first DNA vaccines that were brought into clinical trials were a dismal failure. And it took us many years to figure out what was wrong with them and how to get them to work. And with RNA vaccines, they really never came to the forefront until we figured out strategies of how to actually deliver them. So I'm going to talk a little bit about one particular vaccine strategy that has looked really promising in our lab. This is a replicating RNA vaccine. It's delivered in collaboration with a biotech company right here in Seattle called HDT Bio. We published this recently in Science Translational Medicine. And we're focused on a lot of different immunogens that we're testing. The one that I'm going to talk about today is just really using the full-length spike protein from the SARS-CoV-2, the virus that causes COVID-19. But I want to emphasize that a lot of our work is in collaboration with both biotechs here in Seattle, as well as other collaborators here at the University of Washington. We're working kind of together as a team. So when we first, in January, the sequence for SARS-CoV-2 was published, and that's really where we got really going in terms of developing this vaccine candidate. You can see the very quick trajectory of this particular vaccine. And we knew, from all the different types of vaccines that we had available to us, that RNA and DNA vaccines had the best hope of potentially stopping this pandemic quickly. And precisely because you really only need the genetic sequence from that vaccine to be able to design it. Within 7 days after that genome sequence was released, we already had vaccines that we were testing in animal models. And right now, today, we're already in GLP tox studies and looking forward to starting human clinical trials at the end of August and beginning of September. And so what we actually decided to use, there's a number of groups that are obviously using nucleic acid vaccines. You've heard of Moderna's RNA vaccine, and you've heard of a number of other different groups. We are actually working with an RNA vaccine for this particular strategy. And RNA vaccines have a lot of advantages, as I mentioned. You just need the gene sequence to design it. But they're also really amenable to rapid scale up, and they're very stable at room temperature, certain formulations of RNA anyway, as well as DNA vaccines. And importantly, they induce antibody and T-cell responses that we think are going to be important. And so traditional vaccines, they really require a lot more manufacturing process because you have to grow them, produce them in cells and then purify them, whereas RNA is just kind of ready to go once you've actually manufactured it. And so this is traditional vaccines that like Moderna is using. What's different about ours is, I'm going to speak a little bit about that in a minute, but what's different about ours is that we are using what's called a self-amplifying or self-replicating RNA vaccine. And we think this is going to be a lot more effective than your standard messenger RNA vaccine, because basically what ends up happening is that we include in our vaccine another protein that instructs that RNA to replicate itself multiple times. And so if you get more copies of this RNA, is going to make more of that protein, and then more protein will make a stronger immune response. In addition, this sort of signal back to the RNA to replicate itself actually makes it even more immunogenic, so it sort of acts as an adjuvant to itself. And so I kind of want to get back to the story about the antibody and T-cell responses. I really think that a lot of vaccines are really focused on the antibody, and antibody really does a very effective job, and most of our vaccines are dependent on antibody actually protecting against an infection, because the antibodies are able to block an infection. But we think that T-cell responses may also be really important for this particular vaccine. In the event that, say, your antibodies wane to certain levels that are not at threshold to protect, and that virus can get past the antibodies, these killer T-cells can actually end up finding an infected cell and eliminating it from the body. So we think these two different mechanisms working in combination might make a much more effective vaccine. And RNA vaccines in particular are very effective in inducing both of those responses. And so one of the things that we really needed to do, though, is that RNA has to get into cells. It just doesn't work just by injecting it, otherwise it just degrades. And these formulations that they use is called a lipid nanoparticle-based formulation. And most companies, Moderna and Pfizer and other groups, are using these lipid nanoparticles to insert the RNA into the lipid nanoparticle. What we did a little bit differently in collaboration with this biotech company here in Seattle is that they came up with a formulation that's a little bit different. Instead of actually having the nanoparticle where you had to put the RNA inside, they made one that allowed you to actually have the RNA go on the outside. It works the same way in the sense that it helps to transfer that RNA into the cell, and it also stabilizes the RNA so it doesn't degrade when it goes in the body. But there's some particular advantages, and one advantage is that this particular formulation, you can manufacture the nanoparticles separate from the RNA and store those separately at room temperature for quite some time, or just at refrigeration. They got very long shelf life. And then you just mix them right before you inoculate them. In contrast, with the lipid nanoparticles that Moderna and other groups are making, they actually use a very complex process to actually get that RNA inside that nanoparticle. And that actually then has to be scaled up and manufactured, which has potentially a number of difficulties. In addition, it actually has, right now, its shelf life has to be stored in the freezer. I'm sure they're looking to see if they can store it at room temperature. But right now it would have to be transferred, need a cold chain to be able to transfer that worldwide. The other issue is that this particular formulation uses cholesterol. Right now there's a worldwide limit in terms of amount of that, and that might be a barrier to scaling up, whereas this particular formulation doesn't require that cholesterol. All of the elements can be sourced immediately. So we thought that this particular formulation would be really useful for delivering our replicating RNA in terms of meeting the demands of a pandemic vaccine. And so we did publish this article, as I mentioned, and I'm not going to go through all of the data. And just summarize to you that what we did see was that a single dose of this particular vaccine looks really promising. We were able to induce levels of antibody that are comparable to other levels that have protected animals from infection. And those antibodies seem to be sustained. We're now at 4+ months now, and we're still seeing those antibodies stay pretty high. We also saw those T-cell responses that we wanted to induce. And then we also saw strong responses in aged animals, which we think is going to be real important to be able to develop a vaccine for the elderly. This is just some data showing here that when we actually immunize these are in monkeys with different doses of this RNA vaccine. You can see that there's a 250 microgram dose. We've recently tried just even a 10-fold lower dose of only 25 micrograms. You can see we're seeing antibody titers on par with that higher dose. And these antibodies are now quite sustained. We're out to 120 days, well, actually 160 days now after the immunization. We're still seeing the antibodies sustained. So I always tell people that, that with vaccines, we try to do better than nature. So when you hear about the reports about in convalescent, patients, their antibodies are waning quickly, the approach for a vaccine is really to try to do better than that. And we're hoping that vaccines are going to be much more effective in inducing more sustained immune responses. Now we're proceeding forward with this 25 microgram is going to be the highest dose that will be tested in human trials. And this is just kind of an example of a compressed human clinical trial, which I'm sure other people are going to talk about this more. But traditionally these phase 1, 2, and 3 phases happen sequentially, but to accelerate a vaccine development, they now overlap. And what's interesting here is that they've already started their massive scale up. Even as the phase 1 starts, they'll be starting that scale up. This is what a lot of the companies are doing. They're already starting their manufacture. And that there's no risk really in terms of the safety, but what the risk is that at the end, some of the safety things are not passed or it's not efficacious, they won't be able to license. So they'll have a warehouse full of vaccines that they won't be able to use. So that's kind of, where we're going right now. This is where we're at right here, just in phase 1, but you can see there's a lot of different vaccines that are already in phase 3, and even one in China that has been licensed for limited use in the military. And so there's a lot of vaccines coming through. I get a lot of questions about, well, are you just another Me Too? I really don't think there's going to be one silver bullet vaccine out there that's going to solve all the problems, because I don't think all vaccines are going to be able to meet all the features that I think an effective vaccine to stop the pandemic is going to need. You might have some that are fast and cost effective, but their immune responses may not last very long. You might have one that induces immunity in a single shot, but not so well in the elderly. So you're going to need a combination, I think, of maybe 5 to 7 vaccines that get licensed and developed and distributed worldwide to be able to stop the pandemic. I liken it often to my son, who's an archer, won a national competition, not by actually getting one in the center, but multiple ones close to that center and being able to, sort of win the race in a sense. And so I'm going to leave you with this sort of a cartoon, because once we have the vaccines, who's going to get it first? That's not my job. I make the vaccine, but I don't know who's going to end up getting it first. So I'll just let it go there.
Great, thanks, Deb. Will, I'm going to turn it over to you and let you talk to us about what you're doing and any quick insights that you have.
Sure, I didn't prepare any slides. I was conceiving of this more of a description of
kind of
what we've been up to at the COVID Prevention Network. Essentially, I think, this starts with a lot of people in the spring when COVID hit, and I have some clinical duties, and so I was working at the VA, and I was putting on the protective equipment to go into someone who was sick with COVID. And I don't know if you know the VA in Seattle, but it overlooks a golf course, and there were these older guys out there playing golf on the golf course while I was putting on the moon suit. So it was, there's been a sort of disconnect between the acuity that I felt and that the sort of general response to COVID. So, essentially, I had graduated infectious disease fellowship at the University of Washington with a background in sort of basic immunology, and Jim and Larry offered me a position in a more sort of applied approach with a vaccine trials network, which was the HIV Vaccine Trials Network. In the spring, in response to sort of a directive from Tony Fauci, the network essentially was wrapped up in the national response to the COVID pandemic with the specific eye towards efficacy trials of a variety of vaccine candidates. So currently there are 5 vaccine candidates that are going to be tested within the COVID Prevention Network. Now, in terms of what if there's one sort of take-home lesson or one sort of thing that I would impart to the audience, is that it would be logistics, and that the actual mechanics of performing one of these trials is an incredibly complicated endeavor, and it's sort of taught me a lot. And I think very early on in the pandemic, Larry very presciently said, we should do a natural history study of people with acute COVID to sort of work out some of the kinks of how do you actually interact with people who are suspected of COVID, of having COVID in a safe way for research staff. How do you draw specimens on them? How do you get them into the clinic? What are the sort of procedures for doing so? And so that was sort of the first thing we did, was we got up and running a natural history study of essentially outpatient COVID, which I will say is still pretty understudied. Most of the cohorts that have been described and many of the samples that you're seeing in many of the papers that are being described are really drawn from patients with moderate or severe disease who are sort of hospitalized with COVID. And the focus of a vaccine trial, while it is intended to sort of capture the sort of moderate to severe disease, the more likely scenario and what's a more sort of common outcome is actually mild disease. And I think the factors that influence that split are not particularly well understood, and that population of outpatient COVID disease has not been particularly well studied. So that's sort of the first shoe to drop. And the lessons learned from that have sort of directly translated to the vaccine trials, because as probably many people are aware, the way the vaccine trial works is it's essentially it's an event-driven trial, meaning that you randomize people to placebo or to the vaccine, and then you follow them over time to see if the vaccine is efficacious in preventing COVID in a real-world setting. And so the sort of the mechanics of doing that is you have to be able to diagnose COVID very quickly. You have to have efficient clinical monitoring programs in place to make sure that the vaccine, or that the participants who come down with COVID are safe and are being managed appropriately. It's easy to say that, but to actually accomplish that is an inordinate logistical feat. So, and I will say that currently, you may have read in the papers that one of the trials started very recently, and another one is starting very soon, and it's been an absolute whirlwind. And so, just as a word of advice, if there are any sort of younger folks in the audience, I don't know if folks have seen that show Chernobyl, but I have a lot of sympathy for those sort of backwater Ukrainian nuclear power operators, where all of a sudden they're right at the heart of the national experience. And so I think that's been very much my experience, where all of a sudden you're very, very much in the public eye, and you're working very, very incredibly hard to make sure to come up with a vaccine that's safe, efficacious, and sort of satisfies many of the concerns that were outlined earlier. So at that point, I'll pause and sort of pass it over to Jim or Larry.
Well, you're going
Great.
again, but it's Larry here, and I hope you don't think that we're undergoing a nuclear disaster.
No, I think it's more
All right. I'm
the
just teasing you.
it's more
Okay,
the
so
national response element to it that I think I want to highlight, that now we're sort of there are incredible resources being brought to bear on this issue.
all righty, James, you're up next. You're muted though.
Yep.
We can't hear you. There you go.
Yes,
Okay.
thank you, Hilary. Well, I'll follow Will and also and Deb and maybe preempt Larry a little bit by showing what kind of activity we're talking about in the scope of this COVID prevention network, as we've been charged to take on this activity. And the gray bars here illustrate the observational studies that Will had alluded to, the first being the convalescent study that we deployed at our clinical sites around the world. And then an acute response, more natural history study that we deployed shortly thereafter. And as I'm sure you're aware, the Moderna phase 3 trial just started last week, and they're proceeding at a rapid pace to accomplish enrollment of 30,000 people within the span of a couple months. That's going to follow shortly, hopefully sometime in August, with the AstraZeneca phase 3 clinical trial. This is the ChIMPAD from Oxford that will be, that is currently moving through phase 2 clinical trials. We're working closely in a partnership with Sanofi. They're launching their phase 1 clinical trial projected in September, and are hoping to rapidly move that into a phase 3 trial by the end of the year, as you see illustrated in this figure at the bottom. And in between is the Janssen phase 3 trial to start earlier in September. And this is based on their Ad26 vector platform. And Novavax, which is also, like Sanofi, looking at a soluble protein for purposes of inducing primarily antibody immune responses against the virus. Now we have, a number of activities that we have underway. About 4 weeks ago, we launched our Coronavirus Prevention Network, and there was a press release from Dr. Fauci and NIAID regarding the progress that we've made in the few months that we've been operant. And that website, I'd encourage people to go to. It provides a lot of background and information on the clinical trials that we're working on and extensive FAQs, and also importantly provides a link to what we're calling the volunteer screening registry that is collecting critical demographic information from people around the country who are interested in participating in these clinical trials. And that information is then provided to respective clinical trial sites that are seeking individuals in catchment areas where they reside. And once you complete that, it's a 5-minute questionnaire that directs you to, again, a gratitude page with thanks. And as of yesterday, this is an illustration of the number of hits. We've had now over 300,000 people completing this registry for the purposes of the benefit of the clinical trial sites around the country, so that they can really identify those who are most eligible. We'll need literally millions of people who enter this registry to provide the appropriate demographics and risk factors for individuals who will be recruited into these trials. We're seeking individuals who are not just likely to be infected by SARS-CoV-2, but also are at risk for progression to disease, since the primary endpoint of these vaccine efficacy trials is a moderate level of disease, mild to moderate level of disease. So that is the vulnerable populations we've been reading about, who are disproportionately impacted, Black and Hispanic Latinx populations around the country, and we really need to reach into these communities. And thus, Larry has charged us with a considerable communication and community engagement effort that is also underway and will reach the airways in the coming weeks on a national scale that we're very excited about. And we're really focused on that as reaching these populations who are so disproportionately impacted is a very high priority for us. Otherwise, I think the network is focused on a tremendous amount of activities that ranges across the entire scope of work that's required to accomplish these large efficacy trials, ranging from, this community engagement effort I'm discussing, but also the laboratory and the contribution of the statistical and data management efforts, the medical management and oversight of people who become infected with COVID and how best to provide that medical service to these volunteers is a very high priority, and something that Will has also been intimately involved with as far as providing the rationale to the developers and to the funders as to why we really need to prioritize the monitoring of these individuals and making sure that they access the best care as possible. So with that, why don't I transition over to you, Larry?
Larry, you're on mute still. Thanks, Jim.
All right, let me try share screen. I may have a slide or two here that might be useful. So I'm going to take us at the higher 40,000 foot level here, and sort of go back maybe to the beginning as being sort of a complementary approach of when the issue of when Tony called me to say, hey, he wanted me to take this on to sort of figure out how we were going to do vaccine development and how to conceptually take this on. It's the issue of how do you not only do it investigatively, but what's the system that sort of allows one to get the vaccine, which needs to be manufactured as well as distributed, in a line that would sort of streamline everything. And it was really very apparent very early on, even before maybe I even thought about this, was that there was no single vaccine platform that could be manufactured at enough scale to immunize the 4.4 billion adult population, and obviously children need to be vaccinated, so that's 7 billion. So in the US, that's 330 million. There's 220 million adults and 110 million children. So, so how do you conceptually deal with the fact that the press likes to report this race as a race rather than what needs to be, which is really this conceptual framework that we need multiple vaccines to work. We know multiple vaccines to work not only for the scalability, but we actually need them also that they are likely to fit different populations. RNA vaccines look, they have pizzazz, they have scientific pizzazz. We have very little knowledge about their long-term safety. We have no data at the moment in pregnant women. That doesn't mean that they're not safe for pregnant women. It's a data-free zone. There's no experience with them in children. Almost all the vaccines we give children are protein-based vaccines, and they are the sort of tried and true vaccines, especially particle-based vaccines. Our vector vaccines have emerged as a new way of delivering genes, and again, all the vaccines are essentially directed at the spike protein, so the landing gear of the virus to make antibodies. And Ad26 has been for Ebola licensed recently, as well as been experience in pregnant women and some experience in children. So it is interesting that despite all the criticism you get of government and this particular administration, the platform of Operation Warp Speed, or the government, is in COVID-2 vaccines, COVID-19 vaccines, is really, at least in this person's opinion, pretty rational. It's a platform base. It has RNA, it has DNA, it has viral vectors, live viral vectors and replication defective vectors. The chimp ad's not on this slide, and the protein-based vaccines. And so The issue was how do you do this? What is needed, conceptually is to create all the resources of industry, academia, now civil society, and government. And the idea was to develop a situation in which you allow the companies to hold the IND and do it in their way, because they need to file the BLA, and the BLA needs to go in quickly. And we need the BLA to actually sort of democratize the vaccine, getting it licensed and getting it distributed. And hence the collaboration of Big Pharma for their manufacturing. Even though they're individualized trials, we tend to harmonize, we work on harmonizing them so that the endpoints, the laboratories, the immunoassays, and even the clinical trial sites are known. And the hope is, because they're all developed against spike protein, that we can get a correlate of protection. If we get a correlate, then we can actually bridge down to children. We can go into select populations. We can get it out to parts of the world that you don't have to do these large randomized controlled trials. And that's, basically Jim has shown you this slide. So we have in front of us really a task in which each of the trials is 30,000 persons. It's about double the size we actually needed to sort of traditionally, if money was a cost. But time's more important than money, and the advantages that 30,000 brings, which is greater speed to defining a potential endpoint, as well as greater safety. If you have a 20,000 or 15,000, depending whether it's a 2-to-1 or 1-to-1 randomization, you get a decent safety profile out of each of these vaccines, as well as the fact that they're designed to try and get the endpoints within 6 months of them starting. So the most common question we get is, when will we know something? We think the end of December or January is probably the best time. Obviously, in an endpoint-driven trial, a 90% effective vaccine gets to that endpoint quicker than a 50% effective vaccine. But the FDA has been pretty, in my opinion, good and stringent with respect to this, using a 30% lower bound. So the trials will have veracity with respect to safety and efficacy. So science, it's amazing if you think about it, from a virus that's cloned to actually have in the pipeline 5 vaccines ready for phase 3 at this point in time that we're actually planning for, each of 30,000. So the first one started, the RNA vaccine. Both Pfizer and Moderna have RNAs. They're essentially identical RNAs to full-length spike. The chimp adeno, again, full-length spike starts in 2 weeks. The Ad26 starts at the end of September. One of the protein vaccines, the nanoparticles, starts in October, and recombinant protein starts in December. So science is at the point where we now need civil society to help us to enroll. It's really 150,000 people to roll up their sleeves by the end of 2020. You'll start seeing some of these help end the epidemic, help end our uncertainty, because it really is science that's going to lead us out of this. Social distancing or physical distancing certainly has its limitations. We know we have issues with the Black and brown population. These are some of the signboards that you're going to see coming up fairly soon in social media, and also eventually when we get the TV ads out. So campaign is sort of help end the uncertainty and volunteer now. So I'll be quiet, take some questions. And,
okay.
There.
Awesome, thank you. So I've gotten a couple questions about, are we going to talk more about how to deal with vaccine hesitancy, how we plan to reach people, and I wanted to let people know that we are planning a follow-on webinar that'll be specifically focused on those community-oriented questions and deployment questions. So today we have our vaccine development and trials group here, so we're going to focus on questions for them. I'm going to ask you guys what I think is the $1 million question, which is, when blue sky, everything works out perfectly. When's the soonest that you think that we could have a vaccine out there that's reasonably efficacious and that's widely available?
Well, I guess I'll take it first. I want to preface it first because if one read the New York Times yesterday, you know, there's all this issue about, you know, to me, the biggest issue is will we be allowed to do these trials, and will science prevail over politics? And I hope science prevails, because I think there's really no way to responsibly know who to give these vaccines to without doing the trials to determine, are they safe, are they effective, and in whom they are safe and effective. And I think that's the biggest risk to us, both I think as civil society and as scientists and as American scientists, that we need to be left alone to do these trials. There's no question we can do the trials. The Army has been built. They're average 80 sites per trial. Jim, Will, you know, they have, you know, worked their tails off to get us where we are. So the real issue is to be able to generate science data to translate into public policy, you know, as to who should get vaccinated, when they should get vaccinated, and how soon are they going to be vaccinated. Now, you know, some of this is the government is buying things at risk. It's not really knowing how much they really are buying and how much will be available when. So, and also the fact that multiple vaccines are needed. So it's a complicated question that you ask is, okay, we can come up with an answer, let's say in January. You know, you could maybe start vaccinating in February. But how many doses do you have, and how would you distribute that? Who would get that? The National Academy is setting up a panel to do that. Actually, we're delighted Steve Wakefield, who has been with us, is really one of the panelists on the National Academy panel on the priorities of that. So Seattle has a role in that. That's sort of cool. Bill Foege is one of the co-chairs of this of the panel. So you know, these are great questions that you know, we hope that they're great there to answer, that we have effective vaccines so we can you know, participate in that kind of dialogue. But it's complicated.
Yeah, yeah. So for those people who are thinking like, I'm wondering, you know, like, do I want to be part of either the clinical trial, or when it first comes out, do I want to be one of the first people to get the vaccine? Tell us a little bit about, like, what are the possible side effects, like who, you know, what should they be either worried about or not worried about in terms of being either part of the trials in terms of health risks or possible side effects?
Well, Will, you take that. You're the best doctor among us.
So I will tell you that vaccines are safe. There is no other medical intervention that has been as exhaustively studied and has as beneficial a risk benefit profile. I will tell you that sort of flat out, and that's based on an awful lot of experience. I think what is likely is that many of the vaccines will provoke an immune response, which is sort of what they're designed to do. And so what I mean by that is you are likely to feel something over about 20, it depends a little bit on which vaccine you're talking about, but 2 to 3 days, you might not feel tip top. Now, if you were to ask me, would I trade that for being able to get on a plane and go visit my parents without thinking about it? I would trade that in a heartbeat. So, you know, if you are thinking about that, then I think it is based especially on the sort of earlier phase clinical data. It's very likely that that will happen, that people will feel lousy, that a certain percentage of people will not feel great for a day or two after getting the vaccine. I will say that that's the most likely outcome. In terms of sort of longer term outcomes, they'll be exhaustively studied, but we don't necessarily anticipate them. I mean, biological systems are inherently complex, and there may be something that drops that people were totally not anticipating, but I think that that's a pretty low probability event, to be honest with you. And we are gathering the data to answer that question, so we'll be able to know the answer to that question. But I would say that, you know, in terms of the sort of risk benefit, what is a risk would be that you might not feel great for a day or two. And and that there are in any sort of experimental intervention, there are sort of unknowns, but I would say that those are very, very low probability based on an awful lot of experience with vaccines in the past.
So Deb, I saw, as I was seeing you responding to some of the questions in the Q&A, seems like there was disproportionately sort of a like, well, RNA vaccines, it's newer, like, are there some special risks associated with those? Are there any things, I mean, to me, it seems almost like it's RNA, they're coding these proteins. Doesn't seem to me like there's any special risk, but what do I not know?
Yeah, I think, because RNA vaccines are new and they just haven't, unlike a lot of other vaccines, we don't have a lot of history with them in people, and we're seeing it for the first time. So, as scientists, in the preclinical studies, we try to address that even before it gets into human trials, and look at various, aspects. So with RNA, it does have immunostimulatory properties of its own. We think that's good for the vaccine to help it generate an immune response. That there could be a trade-off on that. Does it induce the wrong kind of immune response? And we studied a lot about the first SARS-CoV that emerged in the early 2000s. We learned a lot about what kinds of immune responses you don't want to induce that could, potentially, exacerbate disease or, cause, issues, with that vaccine. So, we've carefully designed the vaccine to try to avoid those kinds of responses, but we won't know for sure until we get in humans. And I can only assure you that in animal models, we don't have any evidence that these vaccines are going to cause any particular type of response that would be of concern. With that said, the dose escalation studies are precisely done to find what dose is going to work and what dose is going to work but still be safe. And that's what we're going to be doing in phase 1 trials.
All righty, we are coming up on closing time. Jim, do you have, since you didn't get a final word in, any final words out to the community in terms of thought, things that people should have on their radar screen?
Well, I just thank you again, Hilary, for bringing us together and the questions that have come up, which I think are fantastic. And also, we need all the help we can to mobilize community and to reach those communities who, as we know, are very disproportionately impacted by this. We've provided the link to the website. It also, you can get there as well by covpn.org. Sometimes that's a little easier to remember or to type out, covpn.org. And, how best to engage in the diaspora of communities around the country and around the world. We're in this for a global effort, and that I think is something that we're also committed to and keeping in mind as we roll these clinical trials out. And thanks very much for the effort and attention here with the Department of Global Health, School of Public Health. It's a great effort, I think, that we have in Seattle, and everyone should be proud of that.
Yeah. So on that note, we've been getting comments from a couple of folks who are on the webinar who either work with communities and are happy to help with outreach, or who work on vaccine hesitancy and are interested in talking and partnering. Is it okay with you guys if they reach out? Who should they be reaching out to about those kind of opportunities to collaborate?
They can reach out to me or Larry. Yeah.
Okay.
I'd be happy to facilitate.
Let me just say they're easy to find on the internet. But if you can't find them for some reason, shoot us an email here. Feel free to email me or the SPH Dean at uw.edu. And thank you guys so much. Thank you so much for taking time out of what is an incredibly hectic work period for you guys. We really appreciate everything that you're doing. Really, I won't say hope that you're successful. We know that you'll be successful. We hope that you're successful soon and through many different paths, and appreciate everything that you guys are doing. So thank you.
All right, thanks.
And thanks to everybody for joining us today.
Thanks, everybody.
Bye. Thank you.